first make sure it's okay for us to.
Yeah,
Fine, yes.
Oh, yeah, I'm fine.
Well, we had decided.
Yeah.
You think they should
No, I don't
work?
know.
Do you want me to
Those
move?
four-
No,
four
I'm fine.
seats there
I'm fine.
for
We're just
Okay.
gonna sit right next to
Sorry, I
you.
took a nice chair though.
Prerogative.
Well, at least
I can give you this nice chair.
Well, but there's a double here. If you swung
I don't know
here,
if
then
teams
you
determine
swing
what actually
here.
needs to be done.
You are lucky.
Certainly don't want the bald guy in front of the camera.
Or do you want me to sit over here? You want-
Well, I'm just saying, right, if you move them to there, is that right?
Fine with me, whatever works. Am I blocking a view?
Not for me.
Is there two?
So that works for you all?
We're good.
Great for us.
Let me get the door just so that we don't have the noise from the cafeteria. Okay, well, good morning.
So good morning. It is December 15th. This is the Joint Task Force on Affordable Accessible Healthcare. And it's really our last full big meeting. And we will meet again early in January to affirm the report that we send back to the legislature. But before we begin, I think Representative Lippert and I each wanted to say a few words to get started, and then we're going to have our consultants walk us through the options.
Yeah.
You want to go ahead?
Perhaps we should introduce ourselves just for the,
Go right ahead.
because we have some folks in the
Yeah,
room who haven't
no,
been in
good.
the room before. Representative Bill Lippert, Chair of the House Healthcare Committee.
Oh, Ginny Lyons, Chair of the Senate Health and Welfare Committee.
Let's just go around the table.
I'm Rich Westman, Senator from Lamoille.
Lori Houghton, representative from Essex Junction.
Joshua Slan, with Health System Transformation.
Julie Trottier with Health System Transformation.
Tim Hill with Health System Transformation.
I'm Beth Waldman, with Health System Transformation. And Hugh Field, Vice Chair of the House Health Care.
Senator Ram Hinsdale, would you like to introduce yourself, please? There.
Sure. Hi. There's my dog Miso right behind me, and I'll be there in person in the afternoon. Senator Keisha Ram Hinsdale on Senate Housing and Economic Development and Senate Government Operations.
Okay. Terrific.
I really don't have a lot to say at this point. I think I'm looking forward to having your presentations. Appreciate our consultants being here in person today to help us understand the proposals in front of us, answer questions, and I'll save comments for during the course of the presentation and committee discussion afterwards.
Terrific. Yeah. First, before we dive into the report and the PowerPoint that is comprehensive, I just wanted to thank our consultants for the work that they've been doing with us. It's been you doing the heavy lifting on our behalf, and we greatly appreciate it. As I went through the options, as we've received them, and then more recently, I've been trying to keep an eye on who is helped, who is affected, how many people will be helped and affected by any of the options that we choose, any or all, and then the time it will take for us to move through any process, including the work that we might have to do with the federal government, any legislative changes that we'll have to make. And I'm just hoping that as we go through this PowerPoint today and the discussion of the options, that we'll get we'll have some clarity about some of those issues, and then where the benefit is for the individual. I know we started out saying we want to make sure that people's pockets aren't empty as a result of healthcare. And we all know that savings in the healthcare system sometimes look terrific, but they don't end up benefiting the individual. So as we go through, I've been trying to keep that at the top of my mind, and we'll see where it goes. And I also know, just a final comment, I know there are a couple of things that are not on the list that we will be looking at in our committees, such as, well, remote access is right there, number 6, so I can't pick that one, but we won't be doing some in-depth, and you won't be doing, I guess, the in-depth analysis that we would otherwise. So thank you so much for your work, and we look forward to having our in-depth questions and conversation today. With that, we should be right on time.
Yeah, let's dive in.
Okay,
Turn it over to Josh.
good morning again, everyone. Great to be here. I'm on slide 2, so just to give everyone an overview of the day, both everyone on the table and everyone around the table and everyone watching. We're going to talk a little bit about the process we went through. We're not going to perseverate on that, but we'll just want to let people know what we've done and how we got to where we are. And then we're going to dive into the cost of growth benchmark, and Beth is going to lead that conversation. We'll at the end of each one of these sections, there's space for discussion, and certainly space for discussion as we go along. And I know these are dense topics, they're heavy topics, but we're going to try to walk through and provide, the key pieces, not every single thing in each one of these, and then make sure we have time to have that robust discussion so that we can move towards the recommendations that you want reflected. From a process standpoint, I want to let folks know that we will be putting, after we get that those recommendations right from this group, we'll be putting together a summary document that goes on top of these documents that would be, what would be carrying around material when you go back into session. So after benchmark, we go into moderate needs supports. That's the long-term care supports area, and we'll walk through that. We have, after that, the lunch break. Right before we go to lunch, we're going to talk a little bit about equity. We have an equity slide that we're going to talk about how equity in each one of these areas that is addressed in each one of the options. Then we have a lunch break. We are going to have, and you're going to see a theme throughout all of these, that knowing what we're doing and being able to measure, what we measure matters. And so as we do big system changes and even small programmatic things, we believe that being able to measure that consistently and longitudinally is important. And you'll see that throughout our presentations today. So one of the things that we are excited to do is to bring Clarify Health to the table. They're one of a number of different vendors that we looked at. There's been a significant change over the last 5 or 6 years in the amount of data that's available and how it can be utilized, non-healthcare data, to support healthcare decision-making. And we're going to demonstrate some of that I hope will help connect some of the dots between some of these options, and also that you'll be able to carry with you into session when you look at other options as they come in front of you. So after that, we're going to walk through the public option, and Tim is going to lead that conversation. And then finally, we'll end with the blueprint for health. Purposefully designed that way because the blueprint for health, I think, is the one that folks here know the most about. And so we wanted to leave that for discussion at the end, knowing that we could manage to time on that one if necessary. So I wanted to be transparent with that was one that I thought we had the most knowledge around the table on. So that's the agenda for today. Slide 3 just has the purpose here. I think the chairs have stated the purpose, and we've talked about it quite a bit, but we wanted to make sure it was out there for everyone. Slide 4 talks briefly about what we've done. So just as a reminder for everyone watching and for all of us, we started with that options list, which was not everything in the world, but a great many things. And we narrowed that down between our first meeting and our second meeting with you all in order to get down to 7 options, right? And as we looked at those 7 options, we prioritized them. And we talked about with you the things that were already being done, bills on the wall, work groups already in process. We were careful to stay in our lane, to stay out of the waiver territory and out of the Medicaid programmatic territories, except where some of the proposals will touch Medicaid and Medicare, but we're not designing the finance and waiver pieces of that, right? That we know that there's others doing that. We know that there's a big workforce group out there doing workforce. And we know after having taken a light look at it, that for remote monitoring and telephonic supports for individuals, that Vermont has done a great deal in that area. And that there's current committees working on a couple of the tough pieces right now. So we didn't dive into store and forward and those issues because Vermont's already tackling them robustly. We did, though, have a great many formal interviews with folks, and many people we met with more than once. So the folks at Dale, the folks at GMCB, the folks at AHS Secretary's Office and DIVA, we went with multiple times. So I do want to recognize that that's a burden for those staff to meet with us. They have full-time jobs. It's part of their job to do this as well. I recognize that from my prior experience, but I wanted to thank them for their support throughout this process across. They've all been very helpful and supportive throughout the process, and we couldn't have produced the report without the staff support and staff at every level of the agency. So. I also wanted to thank your legislative staff as just part of this, that they've been, Jen and Nolan, Stephanie have all been fantastic as always. So again, it makes it easier to do this with everybody's help. In addition, I wanted to point out that we did get into VCures, but it took a long time. And after we got in, that we had access issues that were substantially a problem. There's some learnings there. I think there's probably some after action reporting we could do on that to try and make it better for future folks that are trying to use that data. The data itself is robust and well formatted, but gaining access and maintaining access is something that's important if you're going to be able to really do. And it definitely limited our ability to do as much data as we wanted. Slide 5. Just a reminder for folks again that we use 6 different pieces of criteria that all come right out of both our experience as well as what's required in your statute, in your legislation that you passed for us to make sure we looked at, what could be done with the federal government or what couldn't, and what levels of savings are there for individuals and for the state and employers. How many people are assisted? What's the affordability for these different items? And how long does it take to do it? How long does it take to do anything? We all know, and I just put this, out front for us to start with, and again, which is that each one of these options is a little different, or a lot different, and measuring, therefore, apples and oranges and pears and bananas. We have a whole fruit basket of different measurements to talk about, and that's always true in healthcare. We're going to try and make it as comparable as possible, and we have a slide in the deck to talk about how many people, how much does it cost, how long does it take, and how do these different initiatives interact with each other. So we're going to talk about those things, but I ask us to keep in mind that we try to make them as comparable as possible without being wrong. In other words, without having what's in there not actually make any sense. And there's a bunch of compromises that go in when you do that, right? So it's the graphic to demonstrate that, the tables that we have to demonstrate that are directionally correct. We're going west, yes, that's right, but they're not precisely correct, right? So, and that's because as soon as you start to compare them to each other, you run into comparability issues. But for public policy, it works. For designing the rule to implement it, it doesn't, right? So that's, we didn't get to that point, right, where we're actually designing the program, and we purposefully stayed away from designing the program, right? That's the other people's jobs. And so we wanted to, again, stay in our lane and do what we were asked here. Slide 6 is a list of the options. Again, we're going to be talking about the first 4 here. And as a reminder, postpartum, we understand the administration is putting a proposal together on the postpartum expansion. We know that remote access Vermont is doing a great deal on, and we know that the PBM regulation is on the wall in the committee. And so those are items that are important, but we did not do a deep dive on those last 3. All right, so with that, unless there's any questions, that's my overview of where we are, and I'll turn it over to Beth to start talking about the cost growth benchmark with you.
Great. Well, thank you again for having us. It's nice to be out of my house and in Vermont. I was saying to Josh, I was surprised that there's no snow on the ground. I don't know that that's ever happened when I've been here in December before. So I'm talking about the cost growth option, and really be starting there because this is sort of the broad umbrella option. And to your point, Senator, it doesn't really touch at the very individual level, but what it does do is set the stage for a number of activities, and really sort of marches people towards a target that helps you really focus in on how you're going to help people at an individual level. And you'll see as we go through all of these things that some of them are big and some of them are sort of more individually focused. And together, I think they give you a package in a way. So if you just looked at this by itself, you wouldn't say this is going to save Joe any money. It will maybe in the long run save him money, but not right now. So just to start with that, we're really starting with sort of the big picture here. So for those that we have talked about the cost growth target before, so I'll go through it as a reminder, and please ask me questions as we go if you have any, and we can dive into some discussion. So a cost growth target, as you know, sets a limit on how much a state's healthcare spending can grow each year at the state level, at the provider level, and at the insurer level. This is important again because it really points everybody in the same direction, and it if everybody has to sort of hit a target, the state, the provider, and the insurer, then they're all working together. They're not sort of working against each other. It also, depending on sort of how you set your methodology, can more or less align costs with wage and income growth. And that's really important as we're thinking about affordability for our families, so that healthcare is affordable for the individuals, for businesses, and the states. Because we're looking at it across the board, it is not and should not impact access or health inequities, but also this is something we should sort of continue to look at as we're doing cost growth target, but the things that are happening underneath it are not impacting access or equity.
Hey Beth, Senator Keisha has her hand up. I just wanted to know.
Okay.
I can wait till you're done. I just didn't know how long it would take to be seen with my hand up. Are you done with this slide?
Please jump in.
Okay, so I know you said it has really no impact until year 3. Have you ever seen another state or entity try to have an impact in an earlier year, like start with 0 or set it so that by year 3 there's 0 growth for a couple of years? I mean, I just worry that it's already so astronomically high for people. You know, yeah. I don't know how, if there's a state that's tried to be aggressive with a cost growth benchmark to really have people feel the impact.
So I think there's maybe three states that have any sort of long-term experience with cost growth. Massachusetts is the longest one. I think the lowest their cost growth has been is around 3%. I can't really see it going below that, to be quite honest. I would be surprised if you ever could realistically set a cost growth target that was 0. Really, this is about how you contain the growth as opposed to stopping growth completely. So I think the answer to the question is no, there's no way to get to 0. The question about 0 to 3 years though, when we're talking here about the 3 years for the return on investment, that's really about activities that are going on below the target. So you're going to set a target and say right now your spending is at 5% a year. If you wanted to 5% growth a year, if you wanted to reduce that so it's at 3% a year, you could set that and maybe sort of with targets that are going down a little bit over time to give you some time to get there in a way that doesn't hurt your providers or your individuals, because if you hurt the providers too much, you're going to lose your access. And so it is all a balancing act. But the 3 years is really about having time to sort of look at what options are to sort of contain costs and the things you can do, the activities, and then sort of putting them in place in a responsible way so that you have time to really see the fruits of what you're doing. So it's not, I would say that the 3 years is not necessarily about the cost growth as a whole, but really pieces underneath the cost growth where you're looking at what best practices are that you might put in place to help lower it. So does that help?
Senator Ram, does that help you?
Yeah, sorry, it takes a second to unmute. Yeah, that does help. I just wanted to make sure I asked the question, but I anticipated that kind of answer. Just wanted to know how useful this option is.
Beth, can you expand a little bit on the comment that we can extend this to cover all populations?
Sure.
And I'm thinking about not just all populations, but types of coverage.
Yeah.
Yeah, would be helpful. And then
so-
Representative Donahue has a question.
Sure. So in today, the way your cost growth works at the Green Mountain Care Board is you're taking data directly from VCures. What other states do when they have cost growth targets is not use their all care claims database at all. What they do is they're using aggregated data that's reported by the insurers. And because they're not reporting their sort of individual data, the national insurers haven't in any other state had trouble or refused to share data. And so that right there gives you a way. So you're not using your VCures to do it. You're using a different set of data, and that allows you to expand to all populations.
And it would also, I would infer from that the regulatory process is consistent for private and public.
Yeah.
So in our state, it's bifurcated. I mean, Green Mountain Care Board does approve rates, but the Department of Financial Regulation is in charge of setting those rates and doing the full evaluation. So within that is a.
Yeah, I think there is there's a question about sort of where the responsibility sits
Or how to extend the access to the information for the regulatory board in some way.
Yeah, so there would be some change in legislation that would authorize the Green Mountain Care Board to do it or authorize it to happen someplace else. I mean, I guess that I don't know that you would want to. You have the Green Mountain Care Board. They have the sort of structure in place to do it. They understand the target overall. They're doing it now. But I do hear your point that they don't have the sort of full regulatory authority over that group. But but you maybe could do it jointly with those two groups in some
Sure,
way.
yeah.
But there is something to explore there. And I think that again, and I think there's about 10 or so states that are doing it now, and in none of the states have there been any issues with the national carriers being willing to share their data.
And that's in, I'm sorry. go
Okay,
ahead.
Representative Donahue?
Yep, sure, that's fine.
Well, yeah, I actually, had a follow-up question to that, aside from what I originally
Well, go ahead, let's
raised my hand.
follow up
So,
on the
yeah,
conversation.
because I had asked this question
Yep.
offline, is the ERISA question. There's a huge percentage of our private insurers that we have no control. And when I
Yep.
look at, for instance, the Rhode Island example, there's this whole list of insurers were required, insurers were required, insurers were required to make it work. So I understand them being willing to voluntarily
Yep.
share data, but I don't see how we could implement the enforcement in terms of requirements with any of those groups, which are the vast majority of our private insurance.
And that's true in any, that's
Right.
true in any state, and I think it's a good point. So I'm just looking to see what we said here about Rhode Island.
Because our percentage of those that we can control is much smaller than many other states. So the degree to which we could actually implement anything was my question before.
Well, I think that the states have been able to implement certain things, and you're right. So when there's setting sort of what the growth is in primary care, for example, in Rhode Island, so that it be at 10%, that they wouldn't be able to require that for the insurers overall. And I can go back and see what actually happened and circle back to see what happened with those national carriers, because that data is out there and public to see
Yeah, there
sort
are
of.
five different.
Yeah, and that's
mandatory-
just sort of the example. I think that I think the idea here, and part of the reason for having it sort of be at the state level and the provider level as well, is even though you can't control the individual insurers, you do have licensing control with the providers. And so if you want to have a cap on sort of what your growth is, even though the insurers can't cap, there is sort of a cap on sort of what the growth can be at the provider level. And so those things work together. And the insurers don't want their rates to, if everybody's rates are sort of otherwise staying down, they don't want their rates to go up, right? I understand in Vermont that Blue Cross is 85% of the market, so they don't necessarily have that same sort of competitive question about where somebody would go. But we can look at sort of what the percentages were in other states and how that played out. But what it does do is it sets the tone, and it really it doesn't give all the answers, right? But it does set the tone for what you want to see happen across the state, and it puts some public pressure, because you can, and this is an important thing that happens in Massachusetts, is that they have these public hearings about what has happened. And it's not just about what's happened on the individual market, say where you can regulate it, but where it's happened in the commercial market. So they have to come and they have to explain about what's happened across the board. And the insurer doesn't want to say, yeah, I get your cost growth targets 5%, but that doesn't really apply to me. I can get 10%, right? It's just that publicly they don't want to do that. So it does put some pressure on them to sort of keep their costs towards that target, even if you can't really regulate it in the same way. So it's just extra pressure.
Yeah.
So there really are two different aspects to this, it seems. One is setting a benchmark.
Yep.
And having a process by which benchmarks are set, and not just set for a year, but over a course of time.
Yes.
And then, as you alluded to in the example with Massachusetts, then there's, at least as I read, differing or none,
Yes.
differing mechanisms to actually enforce, if you will, a benchmark. And so I welcome you to say a little bit more about that, because I think there's just like, there seems to be, and this speaks in some ways to Senator Rahm's question of like, well, there's actually been no one who has used this benchmarking process to go to zero at this point. There's been, but there's been some effort on the part of some states to publicly benchmark, and then differing mechanisms
Yes.
at considerably different levels
Yes.
of quote enforcement, if you will, from none to potential.
Yeah.
But maybe you could say a little bit more about that.
Sure. Yep. So you're right. This definitely is a two-pronged process. The first part is that you're setting a benchmark, and by doing that, you're out there saying, this is where we expect cost growth to be. We don't want to see it any higher. Sort of drawing a line in the sand. And then the question is what you do about it, as you said. And some states, Delaware is the sort of big example of this, set the target and stop. They don't do anything to sort of get it to move it towards a lower level. Then you have Massachusetts and Rhode Island on the other end. And really those are the only three examples that have sort of any experience so far. The rest of the states are sort of in the process of setting this up.
Right. And I think that's important for us to just recognize as well.
Yes.
This is not a broadly
Nope.
implemented process.
It is
at this
not.
point.
It is not. In Massachusetts and Rhode Island, they have put in place additional things to sort of help you. So you can't just set it and forget it. But I mean, you could set it and forget it. That's what Delaware is doing. But the level of impact it will have will be smaller than if you do these things under it. And there's various things you can do under it. The sort of public reporting, it could be sort of just a report that somebody puts out and says, this is what our target is. This is sort of where everybody ends up. This is sort of how we hit against it. Then there's sort of the public piece of sort of having a hearing and making people come and sort of actually talk about what they did and why they don't need it. And then there's sort of a further step to get to sort of a corrective action plan,
Right.
where you could sort of be on the way. And then the thing that we've added here that I don't think we've seen in other states is this really sort of tying to meeting the cost growth benchmark, having support to think about what these evidence-based practices are that we're seeing across the country and the emerging technologies, and bringing them in to that process so that you're, as a state, really thinking strategically and long-term about how you keep your cost growth down, and thinking as you set the target, you're not telling any insurer that they have to do a specific thing. Just we're gonna, as we set the target, we're gonna assume that these things are happening so that the savings that we expect or the return on investment is going to be there. And so that's sort of like a third step. And so you're right that as you think about what this option is, it's really just saying you're going to do a cost growth target. There's a lot underneath that in terms of what you can do along the way. And that's sort of where your comfort level is on what, how far you want to take it. But if you want to get to sort of this individual level of having savings in the end, if you think about this as sort of the umbrella to all of the other activities you can do, and knowing that sort of this is out there, and there's sort of a requirement to sort of look at how to continuously keep costs low at the individual level. I think that's how they sort of work together. So hopefully that helps answer your
Yeah,
question.
no, it is. I think it's important to kind of fill that out a little bit more. And I guess maybe one follow-up question is that what we could choose, or one could choose to implement over time, to, if you will, gradually escalate the use of the benchmarking process and the processes that might go into bringing it into alignment and enforcement, et cetera.
Yes.
That this is not an all or nothing choice.
That's correct.
Policy choice.
Absolutely. You could start with just a cost growth benchmark and see how that goes. And then you could say, maybe we want to try to go further and add in these other steps along the way. I will say that Oregon is just starting, and sort of what they plan to do is sort of at the sort of more Massachusetts, Rhode Island side than the Delaware side. So they're a good state to watch in terms of implementation. And I think as you think about the timing of it, and here we say, it's 12 to 18 months, depending on sort of how you start, the sort of the setting of the cost growth is probably about a 12-month piece, I think, realistically. But sort of you could get that up and running and sort of move on to sort of these other phases over time.
Can I just say as an aside, I think identifying some of the states specifically where this is underway or in the process allows us to potentially reach out to colleagues who are in a similar position of responsibility to really get a ground analysis of what's been involved. So that's helpful to me.
So, and we do have some cost growth benchmarks for our hospitals, and they've been following those.
Yes.
Right.
We can't lose sight of that. So it's a matter of extending it more broadly, I think.
Yeah, that's a great point.
Representative Howard.
So my question has changed about 25 times. So for me on this one, I think what I struggle with is we're setting a cost benchmark, but we're not doing anything to change the cost of providing quality healthcare. And we've been doing it with our hospitals, and they've been needing it, but they're not actually all performing very well. And that leads me to think a couple things. One, I liked the comment you made towards the end of Bill's question, where you said we can do all these other things, not just on a benchmark, but best practices. Yeah. Well, technically, I think we're supposed to be doing that today with the Altera model and the ACO, really. And again, it's like we're trying these things and we're down here, and I feel like we're not really changing the cost, and we're not really helping the system stay afloat. So how would this bring us up to doing those things?
Yeah. So I think it's all in how you implement it, right? Again, the cost target is going to give you sort of something to aim for, and then it's going to give you the sort of potentially the tools to look at things to implement evidence-based practices across the board by saying, hey, we're going to assume that these things are going to happen as we're setting the cost growth. I think your point about the quality of care that's being provided is really important. And so to measure that alongside, so to make sure that as you cut costs, you're not cutting access, or you're not cutting outcomes, but improving them as you do it. And that's what these emerging technologies and the best practices should be doing. So having in place an ongoing process and way to sort of look at, there's so much that's happening all the time. And so having a way to sort of in a structured way, look at what's happening and see what can work in Vermont, and always being on top of that instead of sort of waiting to see sort of what's coming down the pipe because another state has done it or somewhere else. This would give you sort of hopefully a way to say up front, what are these pieces we can put in place that can improve our quality while it's containing our costs. And so, there's not sort of a silver bullet way to say like, this is the technology and this is how we're going to contain the cost. But if you have a structure in place that lets you look at what those things are and think about what it means in the context of Vermont, I think it can help sort of, but having the target is sort of the first step to sort of how you measure it on a consistent basis across the years and across your providers and insurers and payers.
So a quick follow-up, if that's okay. So, and that all makes sense. And I think it's, as I'm sure you would agree, it's easier said than done.
Absolutely.
And so in Vermont, we've done the cost growth benchmark with hospitals, and we've done the ACO to do best practices and population health. And
Take it, take your time.
It was gonna be really good too.
Hospital.
It's been a weird day. And, oh, and I know, thank you for the moment. And it's all been, I'll say at will. There's been no, you have to be in the system. So does this require to be in the system? I mean, we need some sticks to go with the carrots we've been putting out.
Accountability.
Accountability, thank you.
Yeah.
Does that, are you saying that should be in here? And it is something that when we say you're in, you're in?
Yeah, I mean, I think that sort of is the option sort of along the path, like how far do you go? And to Representative Donahue's original question about sort of how do we get in these insurers that aren't sort of part of the mix? That's where I think the sort of public hearing where they have to report on what they're doing, it just sort of puts it out there, and it is, nobody wants to sort of have to go before a hearing and publicly be, you know, shamed, for lack of a better word, for sort of being an outlier in the sort of growth. And so I think that sort of pressure in itself is the stick, and right now that doesn't happen, right? You're setting that cost growth, you do the hospital things, but you're not sort of looking across the board in that same way. And so, you know, you're always going to have this issue that there's these ERISA plans that you don't have total regulatory control over. So the sticks that you have are going to be different for them, but still sort of being able to sort of hold them publicly accountable for the growth and reporting sort of to their consumers about why they're so out of line. You know, I think that can help.
So can I just add to that succinctly, the tools that we're trying to help frame up here are the process, right? For actually bringing ideas in, vetting them, getting a return on investment on them. And that process would involve a stakeholder process that would involve the hospitals and the insurers, and right, as part of that vetting process. And the stick is rate setting on the back end, right? So, and rate setting is empowered by having identified proposals that have gone through a process that's transparent and that puts a dollar figure on it, right? And so when you put a dollar figure on a series of discrete options, whether or not you mandate that you must do this option, you can mandate that you must get that amount of savings. If you have a better option, you didn't like what came out of the stakeholder process, you can go your own route, but you're still going to have the rate setting stick on the back end, which is, this is the process. You've had the right amount of time and the right input, and the options are real. And so that's how we're saying it, right? Like we were trying to give some tools here, and then the stick is rate setting.
And so under that situation, there's really not, there could not be possibly a problem between having two separate regulatory agencies, because you would establish the same requirements for each one.
Yeah, if you had a process that produced an ROI that's this saves $15 million over 3 years,
Yeah.
and you went through that process, financial regulation could build that in the same way that GMCB could build that in.
Right, but what it does is it relieves us of a huge political argument and allows us to go forward with benchmarking overall. Then the problem is within DFR itself, and whether or not actuarial analysis will support benchmark we've established. That becomes another interesting conundrum. But
Yeah, and just to point out, in Massachusetts, the Health Policy Commission is where the cost growth benchmark sits. But the sort of rate setting is either going to be, it's actually in two different places. It would be at the Division of Insurance or the Center for Health Information and Analytics. And so they have that sort of bifurcation too. And so as you get into the details, could look at sort of that model and sort of what they've been able to do to make that.
Thank you. That's helpful.
So I had probably more of a comment than that. I totally agree with a benchmark or a number on the high level.
Yep.
But it's all in the details. And for me, the loudest voices within the healthcare business, and I'm going to talk about business, is the specialist in the high end, and they lobby better than anybody. And they have in the present system the negotiation with the insurance companies over their rates. You know, when you walk into a bigger hospital, they can demand things that smaller places don't. I believe that for myself, that rates for particularly primary care now has to outstrip everything else and be way above your benchmark. And we need to do that to get people into the stuff, catch things before it escalates. So as I look at this, I'm all for setting benchmarks, I'm all for doing that, but the detail for me is how do I, at that same time, shift the money at a much faster rate into the things that I think are going to save us money over time. And I'm not sure in this how that happens. And I understand the rate setting, but I know who will be at the table. And it will be the big guys at the table that have all of the resources in healthcare to do that.
Yeah, those are great points and all true. And I think, again, I'm going to go back to sort of this sort of public reporting of what their rates are in the and the discussion, because it, for example, in Massachusetts, when they do this process, they have the insurers come. They also have the big payers come, the ones that sort of drive the market, and have them report too. And so it gives the having a cost growth target gives the insurers some leverage in those negotiations with it works both ways, right? It gives the insurers leverage with those bigger pay providers who otherwise could sort of hold them hostage to higher rate growth. But it also, on the other hand, gives sort of doesn't let the insurers just sort of raise their premiums willy-nilly. So that's an important piece of it. The other thing is in Rhode Island, along with their cost growth target, and maybe even before they did their cost growth target, they put in place a requirement around primary care spend, and we talked about it briefly in here, but over time it sort of increased how much primary care spend an insurer has to have, and that goes directly to the both sort of pushing up on the rate side and improving the access.
Well, I would just say for me, it's vital that we take the people that are in healthcare that have the smallest voice, which is primary care, and figure out a way to give them more of a voice at the table, because I think that in the long run will make for a healthcare with the cost at the same time. So I certainly think that has to be a piece of it.
That's certainly doable. So we jumped right into the discussion, which is great. I wonder, do you want me to go through the slides that clearly you all have reviewed this and we have talked about it. So I think if you guys have questions, let's keep going.
I did, and mine was a little bit of a prelude, I think, in terms of timing. It seems to me that in this whole piece that we've lost an element. And if I've just forgotten and we decided like last meeting, we're not going to pursue that one, just don't explain it, just tell me I forgot. But when we talked about the concept of the value of goals and targets, which I really do support, that it matters that you know where you're trying to get. We also had been discussing, I thought, a target for how we define affordability for individuals and families. And that's also a piece of the target of where we want to go as what does it mean to be affordable? Because when we talk about slowing growth, that never makes it more affordable for individuals.
Yeah.
So, and that's not in here anymore. Are we dropping that, or?
So I think that's a great question. I'm glad you brought it up, and I'm sorry I didn't include it in these slides. So I had done a separate sort of memo that I think you all got about the affordability piece and sort of how you could define it. Again, to point to Rhode Island, they do define affordability, and you could do those two things together. I think that I might be wrong here, but Vermont has looked at affordability before in terms of
Setting a goal, like not to set a
No,
goal.
the definition.
No, and that's what, I knew there was that discussion, but if this is framing, here's our final piece, then we are losing that discussion from it.
Well, and I wanted to raise the same question, because as I was reviewing the work that had been presented to us, I came across I kept thinking, it used to be benchmark and affordability. And I think that I for one still have a very real interest in thinking further about affordability standards, and whether that's something we talk about today or we asked to think about more still. I would like to put that on the table as well, because I think that that was an initial piece that certainly none of these are going to solve a problem entirely, but I think to really be able to think about an affordability standard is important, especially in light of, I'll just say in the last 24 hours, the last 48 hours, I've been getting emails from folks saying my premiums just went up to a point where I can't afford them anymore. The premiums are now more than X percentage of my income, and I think when we were talking about, in some ways, an affordability standard was established. In some ways, I think with the extended premium tax credits, where I think an 8.5% target was talked about. But some folks are saying, well, but that isn't playing out in my experience. And so anyway, I just think it's a piece that I would like, if it's possible, for us to revisit further.
And I think you could, so the states that Rhode Island and Massachusetts both do things to look at affordability, but they do it separate from their cost benchmark. And so you could do it together, so that you're setting sort of both things sort of simultaneously and thinking about that as you're thinking about what your cost growth target is, and what's affordable for families, and sort of how to get there. I think one thing that we've seen as we think about the affordability, right now, the affordability standards that are out there are looking at sort of premiums and not sort of the full.
We talked about that, right? It
And so
needs to
you
be the
really
whole.
need to sort of make it a broader thing, and to the extent at the federal level, when they're looking at sort of affordability in terms of healthcare, they look at it at the individual level as opposed to the family level. So there's a lot of things you could do around affordability. I think that what I think I would recommend is that you have sort of two things that are sort of working together, but sort of not combined. Because I think what you would have to have is sort of, if you think about it, you'd have to have cost growth here, and affordability is going to be perhaps lower, right? And so you're going to want to sort of move it down, but you're not going to be able to get there right away. To the question about like how you get to 0%, like
I
right,
think that was, that's Senator.
right? So, but I guess that gets to the question about the affordability. That's why that question is there.
So
So
I think, one of the real values is if you've got this concept there, it helps you just through defining it to identify
Yes.
the subgroups who are furthest from it.
Yeah.
And
Yeah.
say, we need a focus here because this
Yeah.
group, and some we can't, you know, the feds have to fix the family glitch, but there are others that could help us define, here's where we really need to try to do something.
Right, and I think we could, so what we could do in the final report is work that in so that there's, both of them are happening, and that you could, you could start out with two things that are sort of there and aligned, and then sort of think down the road about how they can work better together, but sort of set both things.
That's also true for access, and the implication is for clinical improvement over time, utilizing information like BQers or other, and the way is similar to what the ACO is doing in terms of determining best clinical practice, or what the blueprint is doing. So combining affordability and access, quality access, they all need to converge at some point. Anyway, yeah. Can you go through the rest of your slides for us, and we'll listen a little bit, and then
Okay.
I'm sure this will stimulate more discussion.
Disclosure masks will not really cover one up.
Masks don't get in the way of us at all.
All right, so let's see. I think we've covered the first slide. So let's move to the second slide. In terms of so the next two slides are really about sort of what you would do as you were implementing it. These are sort of the considerations, the questions you'd have to ask, and the steps you'd have to go through to sort of implement the cost growth benchmark. So the first is, what is your methodology going to be? You need to set one. And these are the steps underneath it. You know, what what counts as a healthcare expenditure? Who are you measuring? What data are you going to use? And I referred to that earlier when I was suggesting that you maybe not use features, but you use sort of an aggregated data report from the insurer so that you can get to everybody and not just who's willing to report. And then how you're going to select what the cost growth indicator is. And again, that could be tied to your gross state product. It could be tied to gross household income. I mean, there's lots of different ways you can set the methodology. And as we showed what other states were doing, you know, there's a variety of options. You wouldn't have to sort of recreate the wheel. There's sort of toolbooks out there about how, you know, how you could do these things. In terms of how you get to the target, are you looking at historical data or forecasted data? What are you adjusting, sort of what's in or out? How often will you adjust it? You know, this is really about the governance. So once you set your target, how do you look at it on a year-over-year basis? Because you could set sort of an annual cost growth target. You could set a target and say, we're going to stick here for the next 3 years, and then we're going to move. So really, from a governance perspective, what are you going to do to sort of look at how to change it? And when you're, are you going to say, this is the methodology we picked, and we're always going to stick with this, or are we going to reconsider the methodology? And there's pros and cons to everything you would do here. These are just sort of the steps along the way that you would have to think about. In terms of the assessment, this is really how are you going to, what data are you going to look at, and how are you going to get it? How are you going to know which patient goes with which insurer or provider? What size the payer and the provider have to be in terms of reporting? You know, you don't want to pick your really small providers and create some burden for them, and so that's why you have that size. And the same with the smaller insurers in the state. How you'll do some risk adjustment, and the methodology for calculating the percentage changes in expenditure. So really, we're getting into the weeds here about exactly what sort of, once you put in place, hey, we're going to do a cost growth target, what does that mean? Like, what are the details about how you're gonna do it?
You know, when you started talking about historical data, and right now, we're getting emails from constituents who say, we can't afford to have the surgery, the necessary surgery. And the prices continue to go up and up and up, so it's really out of reach. So if we start with a different floor, because we know there's a difference between medical inflation and inflation. And I don't know, I can't imagine what medical inflation is right now or will be once we walk out of the pandemic. But I mean, just a question about where do you set the floor for this? If you're gonna start up here, it's gonna continue to be out of reach unless something else happens. So how do we make that kind of decision? It's just like, it's impossible for some of the people who we hear from.
Yeah.
Yeah.
Well, that's why many states are tying it to sort of growth and sort of like a consumer index or sort of the gross state product, because it is sort of, instead of, it's a marker that's sort of out of the healthcare realm, to get it sort of lower. Now, again, it's not getting it to zero. And I will say, sort of with medical costs, because there's such workforce issues right now, that's going to play into the medical costs, right? Because if you have to pay more to get people in. So there's lots of confounding issues that this sort of cost growth, again, isn't going to solve everything. But what it does do, again, is give you a marker and helps sort of contain what the growth would be. So does it completely solve the problem? No. But does it help it from getting worse? Yes. Right. And then when you have these sort of emerging technologies that you're looking at, hopefully that can help. And, without sort of growth, without sort of any containment, you have some years where you see 10, 12% growth. That certainly is unsustainable. So if you keep it down to 3% or 5% even, then yes, people aren't necessarily going to feel the savings, but it's at least not as much pain. And I don't, again, this can't solve all of those problems, but it does give you some ways to sort of contain it and use a methodology that is using costs sort of linked to growth and income, so that it's not a continuously big.
It seems to me that we need to keep in mind that we're looking at different tools, and no single tool is going to solve all of the issues in front of us. And so the question is, in part, given where we are today, what tools can we add to the mix that begin to make an impact at the different points of change that we're looking to make? But I think it's a mistake in any one of these proposals to say this one proposal will address every aspect of what the changes that many of us feel need to happen. And we recognize that that's not achievable.
Right. Yeah.
Okay. I think Senator Hinsdale, do you have your hand up?
No, I don't. I'm sorry. I didn't realize I never put it down. I guess I'll just say that I'm generally, while I have the floor, I'm generally agreeing that I don't think this is a harmful thing to have in the mix as we move forward. And I completely agree with Representative Donahue and others that it would be really nice to still toggle this in some way to an actual family's experience of affordability. So I just generally support the direction we're heading and think this is a one thought solution, not necessarily an action solution.
Okay, well, if you're sitting in a healthcare committee, it might be an action solution.
If we go to the next slide, there's a few more things that would have to be done in terms of setting up what the model is. So what the authority and governance are in terms of collecting the data, doing some calculating and analyzing of the data, publishing those reports, as I said earlier, thinking about procedures and timing for modifying the target, who's reporting, and sort of how you measure compliance with those reportings. And so, and then we've talked about some of the initiatives to support efforts to reduce the cost growth target. In terms of the implementation strategies, there would need to be some legislation that sort of authorizes this and provides some direction. And you can be sort of more or less directive about how far that goes. I think that, in many states, they've sort of set out the strategy and let the sort of methodology be developed as a next step, as opposed to having a methodology being in the legislation. And so the one thing I will say is that this does take some resources to do. And so sort of wherever it sits, whether it's at the Green Mountain Care Board or otherwise, there is sort of additional need for resources in order to do this. I will say from BALIT does a lot of support of cost growth targets across the state. It's sort of in the scheme of things, it's pretty small money to do it. I think whether or not you have sort of consultants support you all the way, or you have a consultant help set you up and then sort of do it on your own, that strategy is good, because there's lots of data, and having people who are continuously familiar with the data and then can help you really think about other things and not just the cost growth target is a good thing. But it is sort of relatively small dollars to sort of put it out there, to sort of do this. It's not, we're not talking millions here at all in order to sort of get this going. So, and if we go to I think this is the last slide. We have sort of some of what we would need to see, I think, in the legislation to make some changes here. We're proposing that it would happen at the Green Mountain Care Board to give them some additional authority and resources to do that, and that's sort of what's
Well, but one of the things that we're all very aware of is that the Green Mountain Care Board was established when we were developing a single payer model system. And what we're looking at here could well change that direction to where we currently are and how we'd like to move forward.
to expand sort of what they're looking at. Yes, I will say that sort of the others, in Massachusetts, the Health Policy Commission has sort of a broader authority than what the Green Mountain Care Board does. For just that reason, it wasn't created. It was created really with the cost growth benchmark and sort of overall, thoughts about how to improve healthcare overall. And so that's the case at Rhode Island. Like they do it out of their Division of Health Insurance.
That's an important point to be made.
Mm-hmm.
Can I just want to comment on a couple of things that were in the brief that we received and in the slide. I missed it. I think just today, when I talked about strengthening the language to require Green Mountain Care Board to set a comprehensive benchmark, a statewide benchmark, which will allow for a public vote after a public comment period. I read that to mean a vote at the ballot box.
Right,
And I was like,
Yeah.
this is a novel idea.
I did the exact same
And
thing.
I was like, really knocked back on my heels. It's like,
Sorry about that.
In
and,
public,
but
yeah.
I think a clarification may be in order that we're talking about a publicly
Yeah. Sorry about
vote
that.
of the
Public meeting.
in a public meeting, as opposed to
That's funny.
submitting it to a referendum,
Transparency.
which I just thought is, whoa, that's quite a shift. And also, there's some suggestion that, if the legislature didn't set the benchmark, I personally think it's not even a question that the legislature should not be setting the benchmark, but this really goes well beyond the level of
Yeah.
expertise. So for me, that's a non-starter, that the legislatures ourselves should be setting a benchmark for healthcare.
Yeah, I don't disagree with you. I just,
Yeah.
There are states that do set, that the set legislative.
I don't think that there's
I
any
don't
state
think
where
there's
the
any state that's
legislature has set
Good
the
to know.
benchmark. They have all sort of left it to whatever the state agency is that
Yeah.
they've, given the authority to.
Yeah,
We really don't want that.
yeah, no, I just don't think that's.
I mean, I do think that, legislators are, participate in those public hearings.
Right.
Yeah,
Okay.
Yes.
so,
Okay, so I think the next slide just says discussion,
I
which
think
we've done. I don't know if there's any more questions you want. I will be here all day though, so if there's additional questions that come up on this.
Well, but as we're going forward, there's a little section in each of these that talks about relationship with other options. So you're sure to get questions.
Yeah, I mean, I think really this is sort of your umbrella and it sort of helps set the direction for the other. So how much and sort of how much this can be effective is, I think, directly related to how many tools there are to help enforce what, stay within that cost growth. How much of it is sort of a suggestion versus that we're really going to try to hold people's feet to the fire about not going above this amount.
Well, and there's a lot that happens in negotiations between private insurers and larger healthcare entities that is in many ways out of our hands, but to establish some benchmark for those folks, I think is probably important. So it'll be an interesting process as we go forward.
Those are the loud voices.
Yeah, those are the voices. Right. Anything else?
should we move to the next?
We can.
Just in terms of time, I think
Yeah.
that we might do well to.
We can fit whatever we need to in whatever time we have available. We can talk faster.
Cut off our questions, we'll make a lot of noise.
Well, but listen,
But
I think this has been,
But
this
I
is
think
very
this is
healthy.
this is really the first time that we've really
Right.
had a chance to really engage deeply with this, and I think that, I think it's important that we have that opportunity. So,
Yeah, and thank you. It was great to sort of be able to jump right in and
Thank you.
to the meat of it. So I appreciate it.
Great. So we're on to,
Moderate needs.
Yeah.
Slide 12. So this one, I'm gonna lead us through the conversation on, and this one is, think of it as a much more detailed one, but before I go into sort of the details of how this gets done and who it helps, I wanna take a quick step back and think about long-term care and the aging of the population and the additional disabilities being identified within our populations. These are macro trends, and Vermont leads the nation in some of these trends, in the aging of our population and the percent folks with identified disabilities. And so it's important also to know that currently the default long-term care for everyone except for multimillionaires is Medicaid. And people have to, in order to get there, have to spend down their assets, which means sell everything they've accumulated over their lifetime in order to pay for their last year or two of life, right? And for some people that happens 20 years before the last year or two of life or longer. So when we think about all the things, and then in the context of this, Vermont has done a tremendous amount of stuff, okay? Vermont led the nation in moving out and closing nursing home beds. I remember when Patrick Flood was having those discussions years and years ago. Very, very difficult discussions, shutting down homes, shutting down beds, shutting down homes, and building community capacity. Notwithstanding the workforce issues that we have today that may make it challenging to continue to expand at this moment, continue to expand in our community is what will happen. It's better for consumers. Consumers want it, and on average, it costs less anyway. So that's where we are. We have now, to some detail, we have highest, high, and moderate need groups. And the highest and higher are large groups of people that are in nursing facilities, that are in or not in nursing facilities, but receiving nursing facility level of care. Both of those things, the highest need group, are in. And then there's folks that are not yet at that level of need, but still have some needs. And we currently have a moderate needs group in Vermont. There's about 1,000 people at any point in time. It's varied between 800 and 1,200 or 1,300 over the last several, decades. And the amount that they spend on healthcare varies dramatically. If you look at any 6-month or 12-month period, the people in that group of 1,000, some of them spend $0 or $12, very close to zero in any one 12-month period. And others spend 300, 400, 500,000. Moderate needs, but they were spending tons of money. Very few people at that top end, but every year there's a few, 10, 15 of those 1,000 that are way, way, way up on the expenditure. If you look, so we always say in healthcare, 1 year is not a trend, right? So 3 years, good period to actually see what's happening. What we did here was we said, listen, we know that Vermonters need more assistance with their activities of daily living, and they're going to need more assistance in the future. We also know that getting upstream, so not waiting till someone has nursing level of need in order to start paying for stuff, can have a substantial impact on the trend line for costs. Both of those families, so think of families that are in the commercial market that are 45, 55 years old. Think of families with a Medicare eligible, young Medicare eligible individual who's 65, 60, 68 years old and is having their first issue where they had a fall, they slammed their arm in a door, but they're at an age where they need some assistance, and they go to search for that. The moderate needs group today, if you come in during the wrong month for the wrong community center, they'll say, sorry, you have to go on the waiting list, because there's a limit, right, today to that. And right at any point in time, that waiting list is between 300 and 700 people. We say 500 to 700 on the list. In fact, the Department of Aging and Independent Living at the state level doesn't manage that wait list. That wait list is managed at the community level, and they have to aggregate sort of who's on the wait list. And it's not consistently kept up. And that's not a ding on the department. That's the process that's been used at the community level to keep track of what is a small group of individuals with a small budget compared to all the other things that we do. HST believes, though, that expanding access in this area to moderate needs can have a powerful impact over time, and that, to just move to the punchline, that by, and then I'll go through all the detail, right? But so, but that by doing an expansion there, and we're really calling it an extension, by extending who has access, both extending to individuals with lower levels of need, to younger individuals, and to individuals with higher levels of income. All of those types of expansions provide the opportunity for individuals who have their first opportunity, not opportunity, that's the wrong word, who have the first occasion where they need this assistance to have it meaningfully available to them, right? So that's what this is in a nutshell. And there's a bunch of data here. There's a data appendix that we included, a technical appendix. There's a bunch more work that should be done on the data. That none of that would stop you from actually implementing an expansion, because you can control it with some big, wait list is a sledgehammer for controlling it. But we control a little more carefully than that. with some additional clinical efforts to make sure we know what levels of needs are, and also with some flexible funding to allow people to do things in a more flexible way. All of those things come with caveats, but that's the high level. And think about it over the next 5, 10, 20 years. To the extent that we make those investments today and we demonstrate the ROI on those, we actually keep track of how many people in this cohort, and we can do this. We can look at a cohort today, enroll them in a program, follow them over multiple years. We can do it, we don't do it, right? That's a choice, right? The fact that we haven't done that is a choice. And today, it's cheaper and easier to do that. We have more data, better data, and so it's easier than it used to be, right? Like there's no long form, the white and green paper that someone has to print out of a thing. We're way beyond that, right? So the time, is now. Start anywhere. This is one of those things that we've begun a long time ago, and we're taking it and saying you could take it a little bit further. You could take it a lot further, depending on where you want to go. And how much you want to do today versus tomorrow.
Can I just ask a clarifying question? Is the limit you're talking to on the 1,000 Vermonters, is that a financial limit or a workforce limit?
It's a financial limit
Okay.
at this point for the enrollment.
Okay.
The actual, but if you brought in the Dale folks, they would say that there are people. So they have two issues. They put a care plan together for someone, and they say you get this many hours of this, and this many hours of that, and this much support here, and this much flex funding. And they say, okay, so that's this much in budget for the year. And when they spend their whole budget on plans, they say you can't enroll anyone else, right? But at the end of every year, there's money left over, and that's a workforce issue. Not always a workforce issue, but a lot of workforce issue. And in the vein of sympathy loves company, every state has that issue. That doesn't solve our problem. I'll just say that we've talked about it before, right? It's a problem. We have a couple of ideas on that front.
So you say 300% of the SSI payment standard. I don't. What is that?
That's on, I can try on another slide. Let's skip to that real quick.
Because normally we say 300% of poverty, and no, that's the
Oh, there it
standard
is.
we generally use. That's a different term than what I usually do.
Yeah. It is a different
Is
term.
that group the estimate, 1,000 people that would be under that level?
So today, well, is that the same number, Julie?
Yeah, that's the dollar amount.
That's the dollar amount.
I mean, it's different for individuals versus a couple. That's
Yeah, it's not a term that we use all that much. We use 300%
yeah.
of poverty. So I'm looking at that I'm just trying to translate it.
Is this SSI eligibility? Are we talking about these folks being eligible for SSI, and that's why we're using that as a standard, or is it?
No, it's just the standard MNG
Okay.
uses today.
Right, right.
So does that mean that if you have other income than SSI, that's not
No.
counted, or?
No.
No, okay. It's just that.
It's just sort of the calculation we use to get there.
Right.
It means that.
Yeah, but they usually do.
But I want to add a piece here, because I have to confess that as we've been talking about different options, there was this moment when I realized, why am I not understanding this in the same way? And part of it is because, at least on the House side, this is the jurisdiction of a different committee.
Yeah.
This is not the Healthcare Committee's jurisdiction. In the Senate, it's the jurisdiction of the Health and Welfare Committee. In the House, it's the jurisdiction of the Human Services
That's
Committee.
right, and I'm
And
much
so-
more familiar than you are because I
Because you
spent
served-
years on moderate needs
Right.
group and all of that. on
And
human
I
services.
realized that, why is this feeling like a new
Right.
new territory that I'm not
Yes.
understanding initially what people are talking about in the same way? And I think that we need to recognize that in terms of any, and that may not be obvious to our consultants, but it's become obvious to me that it's actually outside of the jurisdiction of the House Healthcare Committee.
But it's within the jurisdiction of the task force.
Yes, but
Yeah,
I'm just,
no, I agree.
so
I
I'm saying, when
understand,
we
yeah.
talk about how to engage in terms of possible implementation, we need to be keeping that in mind as well, and engaging our colleagues who actually are working in parallel to us with a set of issues that.
And I
Well,
actually
even
had a short conversation with the chair of Human Services about the long-term care issue. And so, I think that'll be an opportunity for 3 committees to.
Yeah, I'm not
look-
suggesting
yeah,
that we
no,
don't
no.
look at this. I'm just there's really an aha for me that when some of us do not operate with the same facility of information and background in this area.
And it might mean that it would be worth engaging a little bit of that context before we make decisions on, are these the priorities we want to support? Because if our Human Service Committee says, oh, no, that group's in great shape. No, but I mean, it would be valuable
I
just to
think,
have
you know
their.
what, that decision can be made after we make our recommendations.
Yes.
I don't think we need to expand the conversation right now, but I do understand what you're saying.
So, that preamble leads me to roll through some of these slides now. So 3 big things here on the front page. One is that we want what we measure matters. So for all of these, we're going to say that, and we believe that there should be analytic tools to do identification, stratification, and to follow it longitudinally with return on investment analysis. We further believe that expanding or extending the MNG to additional individuals can happen on the wait list, on Medicare, and on commercial insurance. And think about this really to support these nutrition issues, to support falls prevention, to support social isolation, to support a whole range of things that all are have a substantial potential to impact overall health and welfare for individuals, including mental health for individuals, right? And so let's us not forget that as we age, that doesn't stop us from having, in fact, it may, in some places, you're more prone to some mental health issues. And often, and I remember again, talking to the Department of Aging folks about this, that substance abuse, for example, is an often hidden and forgotten by the general public issue amongst our elders. And finally, but maybe most importantly, leveraging family caregivers and really giving some thought to the programmatic things that could be done with an extension to encourage and facilitate and support family caregivers to provide the services for their family members. It's not that we don't want to, right? But it's often that we don't know how, or that we also have some concerns ourselves that weigh us down emotionally, and we actually know how to provide the supports for individuals to help them be successful, and that should be built into anything we do here. On the next slide, we talk about what's going on in other states. So Vermont, you're not alone, right? You're not alone. Oregon has in front of this is for caregivers in particular, but Oregon has 2 programs, actually waivers in front of CMS right now in this area to do this, and they're on the left coast, but they're very similar to Vermont in this programmatic area where they've done a bunch in this area already, and they're seeking to extend what they've done. And so there's a lot to learn from what they've done and from what Washington State is doing, or proposing to do in both cases here. You'll note, and one of the things I just wanted to draw your attention to in this one is that when you look at Arizona, very different state from Vermont in a lot of ways. They're doing a program also. They're doing it slightly differently, where they're really just pushing out this grant program at $1,000, right? They're uber flexible, uber open-ended, and so that's one approach, a sort of one extreme to the approach. And where Vermont has gone in the past has been closer to what you would consider the Oregon or Washington type models of how to expand programs. And the other thing I'd point out on here is that the dramatic difference in the annual benefits here. And let's remember Hawaii's a very different state from their income capacity and ability to support programs is very different.
And they can regulate everybody.
And they have being an island is different.
Yeah.
So that's where we are in other states.
You just hop across the river.
I've talked a little bit already, but I think it's important to note that we know that people that are 65, that when you look at the 113,000 Vermonters above 65 years old, that if you're sitting in that population, that there's almost a 70% chance you're going to need this support that we're talking about. And so this is everybody's problem. When we say, who does this help? Virtually everyone at some point. Some people maybe only for a few weeks, and some people for many years. So a couple of other things that are important here, and that I think go back to how do we measure we're successful. We would propose that we do measure, that we do keep track of the cohort, and that we identify how many intensive services they do need, right? And that we flow that into the cost growth target. We would also keep track of the percent of the population that spends down into Medicaid for long-term services, because one of the goals should be to reduce the number of people that have to spend down into Medicaid. Washington State.
Vermont's one of two states that has the biggest mega loophole that you don't have to spend down, so.
There is that. Except people do end up still spending through their assets.
Because they don't know that they don't have to, yeah.
But for those of us who don't understand that, and I don't want to go into a whole big thing, but we're saying Vermont no one has to spend down to get into Medicaid to get the services.
Because you create a revocable trust.
Oh,
right.
Revocable, okay.
Yeah.
Got it.
Process.
You just create a revocable trust, and other states don't allow that as a way of not having access to those, because it's revocable, you can take them back at any time.
Okay.
And yet, right, it's not counted, so.
What I'm gonna suggest is, I don't know, is Jen Carby, are you still on the Zoom with us?
Yes.
Oh, would you mind, can you elaborate just a bit on the spend down issue and the revocable trust that Representative Donahue has brought up in terms of accessing healthcare?
I don't think I can at the moment. I have to say my experience in this area is somewhat different from that. So I'm going to have to look into that. My understanding from a revocable trust is I think is that some of the funds are still available and would be counted. And irrevocable trust is different, but I would have to look into that.
Okay, and yeah, because, and it also requires some sophistication on the part of the individual who.
Right.
Yeah,
Well, it was the area agency on aging counselor who told my family,
right.
and I was sort of stunned, because that was a very low level person who was totally aware and was able to say. Yeah.
But when you were talking about earlier, I wrote down on a piece of paper, you either spend it down or work with an attorney. Because in fact, in Vermont, if you work with an attorney, you can sidestep this.
There is a 5-year look back.
Well,
So
certain-
you have to look in advance, and you do have to look with an attorney.
Right.
So that is a barrier
Yeah.
to a big chunk of people.
Good point. I mean, so Vermont might have that window, but it's not necessarily
Accessible to everyone.
transparent or available,
Or equitable.
or equitable. Thank you. Good word.
So, just ask, and we saw in the States before, one at 6, one at 7,500, Hawaii, 25,000. Because most of these people, if you fall and you end up in a place, there's a portion of this that will be covered by whatever coverage you have that's medically related. What we're really talking about is, you know, anything from cleaning to helping you stay afloat. Is there any estimates that anyone's done about what the average cost of that is for those individuals that would fit into the 1,000 category?
Yeah. Let's go to slide 15. So we looked at data from 17 to 19, and we looked at the moderate needs cohort. This spending that you see on your screen is their medical spending on average per member per month. It includes what their insurer pays, and these are not Medicaid, these are either commercially insured or Medicare insured individuals in this chart. And 82% of the individuals in this chart are Medicare insured, okay? The 199.55, the blue number, is the patient per member per month cost. So those are Medicare cost shares, co-payments, or cost share co-payment out of the commercial market. Theoretically, individuals have additional, not theoretically, I believe that individuals have additional out-of-pocket expenses that are not recorded in that 199 because they're not in the insurance system, but they are paying somebody to do something, right? And we're not recording it. So that's not recorded here or reported. So you can see what that number looks like. Now, I want to just do a quick couple caveats. This came out of the VHCures database. The database does not have the full 1,000 people identified as moderate needs. So there's, of the 1,000-ish people, there were 328 that had what's a WM, it's the aid category that flows over from the Medicaid claims into VHCures that had that marker. We don't know, and this is an area for further research, but we don't know how that cohort of 328 might differ from the other 700-ish people that are in the moderate needs group, okay? And we pulled that cohort, everyone with a WM tag in 2019, and then we went backwards in time and looked from January 17th through December 2019 at that entire cohort. So this 1836.38 is the average across those years. But the each of those years is different. So we're averaging it out. There's a bunch of sort of rabbit holes we could go down in talking about how those years are different. The 3 years are in the appendix, and I'm happy to have an offline conversation on it because there's a lot of stuff we can talk about why those 3 years are different from each other. But it'll just drag us in a tough space. So
I would just say most of the services you're talking about for somebody in the home is what an LNA at home health would be doing for a certain number of hours.
Yeah.
What that means is it would be beyond what an LNA might do for home health.
So tell me if this is going in the same direction or not. These dollars here are the total medical expense for these individuals. The expense that MNG, the moderate need group, spends on the moderate need group benefit is a different number than this, right? This is all their medical spend. The moderate need group number for these individuals is in my footnote for slide 17. I'll get there in a minute. So let's go to slide 16 and look at the age breakout and the cohort versus what we did next, so I can explain what we did, and then I'll answer the other question where I think we need to go, which is how much does the moderate needs benefit cost today, and how much would it cost to extend it? So on slide 16, our cohort of 328 is, you'll see it's an N of 306 here. So our cohort of 328 goes to 306 because for some individuals, we don't have some of their information necessarily, like we don't have their age, so they're not on our age, right? And when you look in the back, you'll see some charts are 310. If we don't have the information for them to make that chart, then they're not in it, right? So that's just details. So don't sweat those details. They're important for a statistician, but for us, it's fine. So this 306 person cohort, you can see we have less than 55, 55 to 64, and then as you would expect, lots of Medicare folks. Interestingly, the chart on the right, what we did was we took the 328 individuals and we said, how many of you are in Medicare? How many of you are in commercial? What's your age ranges? What counties do you live in? What are your diagnoses? The top ambulatory sensitive conditions that you had a hospital visit on in the 2017 to 19 period. And we created markers that we then used and went and looked in the population of all Vermonters that are in the database between 45 and that, and all the way at the top. And we narrowed using just the ambulatory sensitive conditions down to 63,000 individuals. So immediately we said there's a whole bunch of people, 40-something thousand in the last 3 years who we can't identify any claims at all that would say that they would be someone that might have an issue that would require some support. We then, and I'm going to go to slide 17 now, the money slide. We then narrowed in order to get to this, the numbers, estimated numbers of Vermonters, 11,000 to 14, and in the Medicare market, and 2,500 to 3,300 in the commercial market. We said of those 63,000 individuals, how many individuals had claims expense that were within 80% of the mean? So those few folks way at the top, we know they're going to end up at highest needs right away. And so let's carve them out for a moment here. We don't know that they're predictive. The power of prediction there is not as powerful for those spenders. And then we have a bunch of folks down at the bottom who spent $12 on an antibiotic, right? That also is not super predictive, even though they went to the hospital and they had an ambulatory care sensitive condition in their claim, right? When we do that, we go from 63,000 down to, at the maximum here, about 18,000 people. And now I want to talk a little bit about this slide. In order to get the dollar amounts for these individuals, the people on the wait list, some of whom are we're double counting. Some of those, all of those 500 to 700 are in our 11,000 to, they're all in that number. So are all the people, 1,000 that are on the program already, right? So there's no way to pull them out of this because we did a population level analysis to come down, to narrow it down. So there's a little bit of, immediately you could take 1,000 people out, you could add these up and then take 1,000 out to get to a total. That said, we also know that I looked at several years, and the years bounce around a lot for the actual payment that are made to support by Choices for Care for the MNG group. They bounce around from 2,000 and something to 3,000 and something annually for those individuals. Okay, so that's a good amount of money, right? $200 to $300 a month to support. We looked at a quarter, it was $700 on average. Remember, they're paying, the biggest thing they pay for is for someone to come in, a non-skilled person, and the rates for that are under 20. They're between $16 and $20 an hour. Now, if they were higher, we could solve some workforce issues there, but that's a different, that costs a lot of money. But that's the biggest single thing that the money gets spent on when you think of how the money gets spent. What we did in this chart was we said, let's use 3,400. Let's cut that in half. and say, we're gonna do an extension that's gonna support caregivers in the home, gonna support nutrition counseling, and a much lighter amount of actual in-home services. Not program designing, just saying that's an option to reduce the total dollar amount. And we said, if we use that number and multiplied it times the people here, we would get these numbers on the right, okay? That's how we got the numbers here. The numbers on the left are too big still. So that's another thing I'll tell you. They're too big because just because you had an ambulatory sensitive condition on your claim does not mean that you are going to need assistance in the home this year, right? Just because you spent $4,000 or $20,000 on medical claims doesn't mean you're going to need, and you have an ambulatory sensitive care condition on your claim, doesn't mean you're going to need support in the home this year. We do know that 70% of these people are going to need support sometime in the next 20 years. So when you think about budgeting this, there's some more work to do, but I want to say on the analysis, and the administration, will need to weigh in on the analysis, but we shouldn't churn the ocean to get this exactly right, because you can't.
Well, I know, I'm pretty clear that you can't, because many of the services that you already are talking about, when home health comes in to somebody that's in need, whether it's the nutritionist that goes around for them, whether it's the physical therapist that comes into the house to help someone through this, all that, part of these services are already being offered.
Are already what?
Already being offered.
Oh, yeah.
And having been the only one that stayed, and having run through 2 generations of my family now, and my father falling and breaking a hip, having cancer, and finally dying after a fall where he cracked the vertebrae in his back and died 2 years ago. I've been through all of this, and home health already offers a whole piece of these, and they offer the services in. So, but there is a beginning and an end to their services, and they don't offer it all. So there is a piece here that I'm just trying to figure out how it all fits when, from the standpoint of I'm on the ground and here's what what you do, and with the services that they do at the end of life. Part of the little piece about that is if you go on hospice in the last year, you're totally covered with their services, but it's not 24 hours in that piece. And that's already covered. So I'm just trying to figure out where you're trying to begin and end with all of this.
My lens is, I'm looking at it from a slightly different point of view, which is from a consumer perspective. There's 2 big questions. Who's going to help me and how am I going to pay for it? Right. So like who's coming into the house, or who do I call? BNA? Who do I call? And then does my insurance cover it? The answer is no, unless you happen to be on Medicaid, right? And then 2, so do I have the out-of-pocket money for it, or do I know about a state program that I might be income eligible for and clinically eligible for, right? And so the issue here on the who, it's going to be the same who's, right? It's going to be the same who's, except in the case where we expand our caregiver relatives and make incentives and make that known and give people the training and supports they need to do it, right? So there's a way to get some other who's in the box, right? Who might not feel comfortable as you might have felt taking care of your dad, right? So that's a 2-pronged thing. The piece here, the second piece of that is focused on who pays for it. And right, the proposal here is if we were to pay for those things and DNA was to hire more people, or we were to pay caregiver relatives a stipend to do some of the work, and we were to add, additional nutritionists, right? Again, workforce, but that these are the prices to supply, right? To pay for, and those would be paid for as a general benefit that would be expanded beyond 100% of FPL, to 300, 400, 500, wherever percent we wanted to move that on in order to adjust how much we were going to spend. And then we would manage the package that would provide the most level of benefit for those individuals that we were expanding to. Importantly, think of the folks that are on the commercial programs today that from a pop health perspective, we could identify and prospectively based on their interactions, ideally HIE level, so near real time from the HIE, from vital instead of from claims, we would be able to offer them the service, right? So now you're getting ahead of that curve, being able to offer someone who pops up in our data. And I think when we see the Clarify conversation, when we see Clarify after lunch, I think that'll help put a fine point on how we sort of change that thinking a little bit, and think about supply and demand as part of the equation as well.
I have a question from Senator Hinsdale, who had to, she's gonna be here, but she had to leave for her appointment. And then my other comment is gonna be, can we go to 12:15 and to finish this option? Let's finish it up before.
Fine with us, however you'd like to go, yeah.
All right, okay, we'll finish it up. But her question really is about equity and where are the areas for discretion about who can access the long-term care support, and do certain communities get left behind? Is there any indication of that? I added that. Is there any indication? Because I think you have a lot of data.
Yeah, so certainly, and again, you're going to see some equity data on a zip code level just after lunch. So I think that'll be a powerful place to think about this. And interestingly, when you see that data, you're going to see that it isn't all in the Northeast Kingdom. It's scattered around, that there's individual zip codes in counties that you would say, they don't have this issue,
Right.
but they do in certain zip codes within that county. That said, we know that for these types of in-home services, that the distance people have to travel, so the Northeast Kingdom is more challenging, right? Because there's not as big a workforce, and getting professionals to travel a long way for a short bit, that logistics is a barrier, right? It's a significant barrier. It can be addressed, and is addressed by the providers that provide in that area, and by some of our rate setting at both the commercial and the Medicaid departments for just regular physician supply, right? But that certainly is an issue. What's mine? So if we go to slide 20, Julie, for a second. What I'll do is start with moderate needs and talk about equity a little bit in answer to this question. And we can talk about some of the other equity impacts too, but I'll talk about the equity one here because it was asked. We can just go back one slide for discussion and discuss this one more detailed. But we do believe that equity, using the blueprint type model for equity, right, where we have all payers paying for something, or all insureds being able to receive something regardless of insurance status, is good, and that extending this to the commercial and Medicare as well as Medicaid folks is an equity issue, right? It does help folks who are just above Medicaid income, folks who are just below Medicare age, to access benefits that they otherwise wouldn't access. It's a small number of total, the commercials that would access this, but those are individuals who would be known to us sooner than they're known today, and we believe that's important and an equity issue. We also believe that focusing on this and providing those family caregivers supports allows people to be cared for at home by someone who does understand and is attuned to the cultural and significance, socioeconomic significances that are important to them. And anywhere we can reduce duplication of services by coordinating better and by identifying individuals earlier in the process so that they receive targeted care instead of, a massive amount of care after every acute episode is powerful across the board. So that's what I would say on that front. And then I'll go back to next slide 19.
I'll let you go back, but I was just gonna comment that having family deliver the services when possible is important, but it's also important that they be reimbursed appropriately, which is one of the issues that we hear about all the time.
I agree with you, and appropriately is not the same as at the professional rate.
Yeah.
So I just want to state that overtly, right?
Yeah.
Can I just do a typo check on that equity impact? You enhance moderate needs, you say regardless of insurer or income level?
It is regardless of.
Yeah, I thought it was 300%.
Well, the income level should be set as part of the policy discussion to manage how much we spend. But when we did the analysis, we looked at insured and commercially insured and Medicare folks. So regardless of insurer, yes.
No, I understand but regardless of income was what I was.
Well, income would
so
be.
That could be anybody. It could be people with 1,000%.
Yes, when we did this analysis here,
okay.
We specifically said above the MNG cutoff, so it is regardless of income level here. So that's another way that this number becomes smaller, right? We didn't want to narrow the discussion right now to 600% of poverty or 400% of poverty. That narrowing can happen, and we'll drive these dollar estimates down as well, right?
Just back up what Senator Lyons had to say. Reimbursement's fine. Having been in that position for a long period of time in doing it, burnout's the biggest thing.
Yeah. That's the
Burnout is the biggest.
That's the biggest, especially for families. Probably only for family. Why don't we go back?
Back on slide 19 for
All right.
discussion.
Oh,
Did we miss some other slides?
no, I don't think so. Did we? Just the 6% increase with Build Back Better and possible 11-15 global commitment health waiver?
Yeah, so I could do that very quickly.
Yeah.
So first of all, to the extent that we get a Build Back Better plan, I'm sure everyone wants to spend that money lots of different ways. This is one way you can spend it, right?
In many, many ways.
This would be an expansion. This would be an extension. It would be new stuff. It would fit whatever criteria CMS has. I'm highly certain. In addition, I believe, and this would require analysis that would need to be done to submit a waiver, but that we could submit a waiver, that we could look at the waivers that are on the states we showed earlier that could be modeled after in part, and that we could commit to doing the multi-year longitudinal analysis and demonstrating that there were savings to Medicare and Medicaid, and that we could ask our federal partner to participate to the extent that those savings to participate in advance of those savings in the assumption that they would occur, and to demonstrate that those savings did occur, upon, prior to renewal. And that's the pitch I would make. And I'm gonna put Tim on the spot and ask Tim to comment on my rosy picture of that.
Well, I think it is a rosy picture. Just restate what your picture is.
That we would demonstrate as a state that we are identifying individuals who otherwise would be on Medicaid or on Medicare in the future, and that we would conduct that rigorous analysis, and we would ask our federal partner to participate in those savings that are the result of the intervention.
Yeah, I mean, I think they're gonna see it both on Medicare and in Medicaid, right? Whether it's through CMMI or through 1115, they're always gonna be interested in ways to share in the savings while at the same time driving and improving care, and in this case, an important market. So I think this may be a little more complicated because it crosses over the two programs, but I think to the extent it's structured in a way that CMS can certainly see their benefit, I think it's worth a conversation, and I think we'd be happy to have the conversation.
And pay for it.
That's
the key.
That is the key.
Converse talk is cheap.
Yeah. Questions, discussion? Ooh, we've been through a lot this morning. This is great. This is terrific. So in terms of extending the moderate needs supports, we are talking about folks who are staying home and taking care of their disabled adult children. Yes or no?
The answer is anyone who's in a position of taking care of individuals. However, my presumption here would be that the vast majority of individuals taking care of the disabled adult children today, those disabled adult children are on a waiver and receiving services. Would we want to, from a policy perspective, extend caregiver education and training to those individuals if they don't have it today? I think that's a good policy to have. I don't know how much of that they get today on that waiver, right? So I don't know the answer to that question about how much.
That is the problem. We do hear a lot from folks who are in that situation. So trying to sort out where they are with respect to support.
Yeah.
Well, I guess I would want to ask the question again. I'm not as familiar, but when you say education and training, that does not necessarily translate into support by itself.
No.
That education and training may be something different than respite or some other kind of support that actually intervenes on the burnout issue.
Agree completely, and professionally, I think that you have more experience, much more experience than I do, Representative Lippert, on the other types of emotional and support that individuals may need for their mental health, right? So I don't want to, again, presuppose what that package of supports would be. And so when I say education and training, for me, it's an inexact, but intended to just point us that there should be supports for those individuals.
I wasn't clear whether that's a term of art that needs to be used in order to qualify for some kind of reimbursement.
No, that was just words out of Josh's mouth. That was not a term of art.
So that's what I think. It needs to be more broadly understood that.
Okay. Let us, unless there's another question or comments, let's take a break. And we'll take a lunch break and we'll come back. Yeah, we'll try for one. See how that goes. Are we off on? Thank you.